Hello and welcome to the Auditing Antics podcast. So today we have a special guest, Scott Kraft. Hi, Scott.
Hi,
I'm
Stephanie.
Hello. I'm glad you made it back in the country for us today. That's a plus.
I don't know if I'm glad to be back in the country, but they do want me to work at some point, so it's probably good to be back.
Yes, that's going to be important. Yeah. So Scott is a good
As
friend of
as
mine.
much as I hated sitting in I was going to say, as much as I hated sitting in Barcelona and eating ham and drinking like a Spanish beer, it is good to be back here with you all.
Yes.
Sounds like such a chore.
Yeah, so Scott is a good friend of mine. We worked together for many years at Doctors Management, and he's working there. Michelle works there as an auditor, so they're good friends and colleagues as well. So today I wanted to tackle the subject that I've been dealing with, and I was telling Scott and Michelle I've been struggling with this some myself recently. When we're dealing with our physicians and APP practitioners that are pretty much experiencing what I would look at as compliance fatigue. I actually had someone recently say to me something along the lines of, get to the point of what it is that you want, because compliance always wants 100%, but that's not going to happen. So where is there some breathing room? So obviously, from our perspective, we're not going to say, oh yeah, just do this part of what we're talking about and maybe we'll be okay in the future. But I've had a lot of challenges with, especially physicians who are supposed to be in leadership roles themselves on the clinical side, really attacking back and not even remaining professional when I'm having to come to them with, real issues that are putting them and the organization at risk. Now, Scott, I know over the years we've talked about this quite a bit because you always want to vent when you go through a situation like this. But what is your first line of defense? I guess I'll say, if you're caught in a moment and, we don't always know the provider's mindset or thoughts about something until we get into that meeting most of the time, unless we're given a heads up. So, what is your go to a lot of the times to try to start de escalating a situation like that when you're met with a lot of anger sometimes or frustrations?
Well, I think for me, part of it is trying to figure out what the root cause of it is and how could I solve it effectively. So one thing that you said that kind of stuck with me that I'll phrase it like from a little bit of a different perspective is a lot of times the provider just wants to know, what do I need to do here? Like, why am I in this meeting? Like, what do you want from me? And I think for us as compliance people, we have to build a foundation, right? Like when we are going to explain to a provider what they have to do, if I'm going to teach a webinar, I can't just make it up. Like I have to have a foundation of sources and appropriate guidance. And, as a compliance person, my tendency is to err on the side of caution, but sometimes the provider doesn't necessarily need the foundation, right? Like sometimes they just need to know, what is it that you need me to do? And so, often I'm asking questions to try to source out like what the root of their frustration is, because sometimes, I think we had talked about like acting out at some point. And sometimes it's just nothing more than acting out. And sometimes the acting out is people, sometimes it's death by a thousand cuts that we all face at work sometimes, where we're being asked to do this one more thing and this one more thing. And so in order to be effective as a solver, I'm always trying to de-escalate by like working past like what's the veneer of frustration I'm getting and what's the actual problem, right? And I think, sometimes for me as I explain it, I'll just jump on the other side of the table and say like, look, it's not you versus me, like it's really us versus them. And so I'm here to help you like kind of pull that rope. And so there's a lot to that answer, but I think you know part of it is getting to the root of what's frustrating them. Sometimes it's just understanding that I just need to you know take it for a few minutes, right? Like they need to vent, and I happen to be the one that's there. So I try not to take it personally, and it's always important not to for me to escalate it, right? So usually, one the last thing I'll say about this is one thing I've learned in life is I think people can only yell at you for so many minutes in a row, and then they just kind of run out of steam, right? It's like when you blow up a balloon and you let the air out, right? It's just, and so if somebody's really venting and frustrated, sometimes I'm just not going to say anything, right? Because I think within 2 or 3 minutes, it's like they're just going to run out of gas. But if I start saying things back to them, it's like shoveling coal into like a steam engine, right? It's just going to kind of keep it
Yeah.
going. So, a lot to think about there.
Yeah, and Michelle, I know that we've talked before about a lot of times those difficult conversations unearthing, issues within the department who's communicating. Maybe they have a new educator. Maybe there's not a lot of consistency internally,
Hmm.
which really leads to issues. One thing before I have you touch on that, though, I want to say, and this goes back to my days working in an office, but I think it's hilarious when you sit back and you listen in on other people's conversations and you hear someone navigate that and their response is anger back. And all of a sudden you're like, oh no, oh no, you shouldn't have said that. Don't go there. Yes, yes, exactly. So, I don't have that situation now, but I remember a lot of times where people were just kind of thrown to the fire and they don't really think about how it's going to come off. So sometimes just the basics of thinking about, wanting to be heard, like you said, Scott, wanting to voice frustrations, and then letting it cool down and going from there. That does really work. And a lot of times that's what I do, Scott, as well as I just sit there. And if I feel, I will say I had one surgeon years ago who just was doing everything possible. He wanted to personally degrade me. And all he did was just like verbal diarrhea of a whole bunch of, really rude, mean, unprofessional things. Luckily, I was remote, so all I had to do was turn down the volume on my headset, and I couldn't hear the words coming out of his mouth. I could just hear that he was still talking, and I waited for it to be done. Luckily, it's not always like that, right? They're usually focusing their frustrations on the man or the system, and the industry in general is getting really difficult to navigate. There's a lot of regulations around what is done. So I get that. And yeah, silence is usually the best approach there. Now,
I
go
One
ahead,
thing though I
Michelle.
want to say, and this is kind of where this is kind of a reason that I have backed off from some of like it's well known from Scott and Stephanie. Like I don't want to do that part of of the job. And part of that reason is because I don't want to be treated that way. And if some for me, my reaction, sure, you can recognize when somebody, like Scott said, there's a lot of frustration and things like that. But somebody trying to personally degrade you, why should you have to take that? Like not smack you, but
Oh,
like why should you have to take that? And my solution to that would be, I don't think we're going to accomplish anything productive today. I'm going to end the meeting here and we can reconvene when we're going to be able to have a fruitful discussion. And it's that's just kind of my take on that. There is a big difference between frustrations directed at a process and things like that, and then frustrations where, because we all know there are those providers out there that think that they can say and do whatever they want towards staff or things like that. And I do think there is a line in the sand where you just need to say, I think we're done for today.
Yeah. And, I've had that happening
oh, I
recently as
100%
well.
agree with that. Like I think,
Go ahead, Scott.
yeah, I mean, I think there has to be and I think it's good to know them in advance, right? But it's good to have like the
Yeah.
red lines around like personal attacks and things of that nature. I think we all, those of us have been in the business for a while. I think women have it harder than men, frankly, in some of these meetings. I think it just, I wish it wasn't that way, right? But I think, I've literally seen the same person treat a woman differently than a man, right? In terms of like the education process. And so there's something to be said for that. But I also think, you're right. Just understanding at some point, either to say, I mean, one thing I always sort of practice for myself is just don't change your demeanor, don't give in, like don't, match their frustration with your own frustration. And so I think, yeah, there's a time where you say, look, we're just not going to accomplish what we need to accomplish today. There's a time when you say, again, in your, the same voice I'm using now, that's not acceptable, right? Like it's in order
Mhm.
for us to accomplish what we need to accomplish productively, we don't need to have personal attacks. And as an external auditor, as a quote outsider, I'm at a stage career wise where I can just go to the client contact and just be like, we're not doing that anymore. Internally, it's a little more challenging, and so I think internally,
Mhm.
it's really important that you have the support of your organization. So if I were an auditor working inside of an organization and I was running into being treated abusively, right? Like, particularly if it was one provider repeatedly, or if it was just a pattern throughout the organization. And the feedback I was getting from my manager or the supervisors or whoever was like, well, they get frustrated and we just have to accept that. Like, I would just be like, resume, life's too short for
Yeah,
that stuff, right? And I
it
think we
is.
all deserve to be treated professionally as we would treat other people.
Yeah, and one thing that I'll say on the flip side of that, because that was a pretty negative take on it that I had, but I have been able to overcome, providers with those types of um, reputations. Like somebody knows I'm going to meet with Dr. So and so, and they're like, "Oh, this is going to be terrible." But I think you said something really important, Scott, and that is approach them as a partner. And I've been able to, have really positive education sessions with providers and outcomes for when when I was going into it being told they're not going to listen to you, they're going to yell at you. But in the end, because I started it out by saying, I'm here to help you, we're a team. We're not like, I'm not here for a punitive reason or to make your life more difficult. I am here to help you. That I think is a really big part of overcoming those types of provider educator relationships.
I
Yeah, and it,
agree, and
it
I think.
becomes difficult with scoring too, because a lot of them do not like to see high error rates, right? I mean, we don't want to see high error rates either. But I've had
Mhm,
some when if they don't have 100%, they're coming into that meeting fuming. So, there are different things that you can't avoid that ultimately definitely could happen. Now, one of the things that I was thinking about with that too is remembering to go into these sessions with your information from a solid source and a solid place. So, if, for example, you're reviewing an audit that you haven't done for a month or two, or if you're reviewing the work of someone else, Scott and I, we've definitely had that situation. We work with other auditors, we didn't personally do the review. You've got to be on the same page. And, there's times, even I know with Michelle, that I've gone into a meeting, I fully understand what your notes say, but I didn't have my eyes on the documentation, and the provider's
mhm,
pushback seems like, okay, maybe they have a point there. But then I go back to you and you're like, "Oh no, this is how that all came to be." And that's why I said that in my comments, and it's like, "Oh, okay, well, there's no way the provider's in the right in that situation." So, a part of building your credibility and building your own confidence is making sure that you know your sources. Don't go in there quoting, my article or Scott's article. You need to have the source of what we're talking about. You need to go in with the CMS documents, or you need to go in with the payer policies. You don't come in and say, oh, well, AAPC says, or this or that, because we all know that that has not always gone very well. another thing with that too, I have in what you were saying, Scott, with there being biases at times. I've had that as well, just from the perspective of being a woman. Also, maybe there's different cultures involved and things like that. And I will tell you, it's one of those things where, as a woman, that's another reason you have to be strong and you need to have your ducks in a row, because you need to go in there fully, approaching the situation as someone who understands it, who's there to help dissect it down, not only look at problems, but look at solutions, and don't back down. You don't want to be argumentative. If there is a difference in opinion, or if you need to go back and look at something, tell them, hey, this is the way that I interpret that guideline. Let me look at it again. Let me follow up with you. There's a lot of things you can do out of panic sometimes to ruin your credibility as well. So you do want to make sure you're being mindful of all of those things before you even get to a session with a practitioner.
I agree. Those are
Yeah, one thing I'd say about that, I think preparation is such a big part of how results are presented sometimes. And I think the reality is, you know, these are somewhat subjective interpretations, right? So if I pick up on one of the things that you had talked about, which I agree with, it involved like having your source material ready. But the reality in some cases is the source material, you wish it said do it this way all the time, but it just sort of gives you a roadmap. And at that point, so I would say it a couple of ways, right? I think if you're talking about an internal audit process where you all work for a certain organization, you want to make sure that your philosophies for how you're going to interpret different aspects of documentation are consistent and defendable and actionable so that everybody is singing from the same song sheet, right? So if you have a specific definition of something like what constitutes appropriate or acceptable documentation for an independent interpretation of imaging, then everybody sort of understands that. Because I know, like, for me as an outsider, one of my frustrations is I'm trying to be like a whisperer to independent interpretation of imaging, right? So, oh, she said CT scan. Does that mean she looked at the scan, right? And so we just could make that a little bit easier. And then I think as far as comments go, the time to be thorough in your comments. So I'll say it a couple of ways. So in terms of educating off of my own audits when time goes by, I've spent a lot of time thinking about how I write comments when I do an audit so that when I pick it up, I know why I did it. So I try not to leave any mystery where I don't want to pick up my findings 45 days later and say, well, I don't know why I went from a 99214 to a 99213 on this. Like, it should be right there. And I would say the same thing. Michelle's maybe heard me say this. I know anybody that we've worked with who's new has heard me say this. And I've basically said to our auditors, like, you should write comments in a way that works for you. But it's important to remember that while the recipient of your comments may not agree with them, and that's fine, if they don't understand them, that's problematic. So if the provider picks up your comments and says, I don't know what you're talking about here, that's on you in a way to make sure that you're explaining that more clearly. And so I think all of that helps you prepare for the conversations because to me that's always, as the reviewer, your greatest asset is you've had the notes, you've reviewed the notes, somebody's reviewed the notes, somebody's made findings. And so if we're going in and flying blind and just saying, well, I'll open the chart and I'll just see what's in there, that's not always great. Now, to be fair, I think someone like Michelle, who I've worked with for many years, I don't feel like I need to open up everything that she does and look at it if I'm doing a meeting off of her audits. But you have to make sure you have that confidence with somebody before you do that. And you work with them, whether they're new. I say, well, okay, I'm going into this call. I want to know what this person saw so that I can pick it up and present it.
Yeah, so Scott, Allison says here she's going to start writing novels for you, just as a heads up.
I
Then
think
you'll
she can
really
do
know.
that. I've saw her most recent comments, and she's already on that path, right? I was like, is this War and Peace, or are we just talking about like an orthopedic audit here? But no, I think I think I think Allison's comments are great. Like they help me understand, like sort of like I said, when I get on the phone with the provider, I know, right? I know
Yeah.
why we said what we said. And if the provider wants to come back and say, well, what's a typical provider argument, right? Like, is it acute and uncomplicated, or is it acute and complicated, right? So that's a subjective measure of disagreement. And so if Allison says that the case is acute and uncomplicated, or I do, or Michelle does, or whoever, and the provider says it's acute and complicated, we may not agree at the outset. We may agree by the end, or we may not, but it sets the stage to have a substantive discussion of what defines complicated. And for me, you know, when I have those conversations, what I'm really trying to get to is like, what am I missing from the documentation? Why didn't I agree with the provider? And how can I articulate that to the provider? Because oftentimes they might be telling me something that isn't in the note, right? So, if I wrote this comment, I haven't done a call on it yet, but I wrote this comment regarding recurrent UTIs for an audit I did recently, and I credited it as acute and uncomplicated. And to me, like recurrent and chronic are different things, right? And so for me, when I have that conversation with the provider, what's going to be centered on for me is like the patient was doing pretty well on the date of the visit. There was not enough granular detail about these recurrent UTIs in terms of frequency, complications, anything that wasn't working. All I really knew was they happen more than once, right? Like I don't even know, like, is it 3 in 3 months? Is it
Duration.
three in like
Yeah.
2 years? Right. And so, I think that sets up a substantive discussion, because I think, for me, when I go in and do education, one of my internal philosophies is, and I can't always do it, but one of my internal philosophies is I don't want the provider to feel like all I'm doing is burdening them with additional documentation responsibilities, where I'm just, you know, challenging them to do more than even I may feel is necessary. So I'm very thoughtful about, to go back to the UTI case, I will sometimes have in my head, like, if you had told me this is the third one in 6 weeks or 2 months, I don't know, like I'm more amenable to that as being complicated or chronic than if you just say this patient tends to get UTIs and usually she gets this and this works and I'm going to give her this, right? I'm like, well, that doesn't sound very complicated to me.
Mhm.
And I wouldn't say it that way, but a lot of times it's some straw man, for either they will tell you something that's a prompt and you say, well, this is the key aspect of the documentation, right? It's like these 4 or 5 words make a big difference.
Yeah.
Mhm.
Yeah. And, recently I've had some situations where there's pretty concerning documentation taking place. And, I'll approach the physician, for example. And in this one situation, the responses being sent back to myself and others that were trying to get everything under control, meaning we knew real time lots of encounters are going out, the charges are being billed, and the notes were extremely deficient. Well, in that situation, I'm being told, well, I've been in the industry for 25 years. I'm a physician and I've been doing this for 25 years. And even to the extent where they were saying, I don't care what compliance has to say, close out my notes, I'm signing them and they're being billed, and just completely refusing to even have a conversation, listen in, and things like that. So, to your point before, Scott, I do feel like we have it a little easier being external because we can go to contacts that we have. But one of the approaches that I've found that really helps when there's a situation like this is tackling it from multiple different angles, meaning bringing in people from different departments and different backgrounds to help. In this particular situation, it was something where I pretty much initially alerted legal internal counsel, like, hey, we've got a problem here, clinical quality, the medical lead physician in place, revenue. We've got to know what's happening with these encounters if they're refusing to even listen. And we know that the result is an encounter that doesn't support any E&M or a lower E&M, that's very problematic. So sometimes we do have to pause, and it's going to go down the route of the organization needing to look at it from really, I guess I'm going to call it a disciplinary standpoint. They're going to have to decide what they're going to allow. And, I know we've said this already, but it's something too where I've really started to push back when I see certain behavior and say, hey, this isn't professional. This is just downright abusive. And, there's certain things that should and should not be tolerated. I do find sometimes it depends too on what the leadership of the organization is like, meaning sometimes it is a board of physician owners and partners. That can be a lot harder to tackle at times. But you really have to look at who the key players are. And if you're struggling with things like this, even if you're internal, look to other people outside of your department who may also see that behavior concerning. Because if there's an issue with compliance and documentation, chances are there's concerns, with the notes I was seeing and just basically saying, oh, I saw the patient continue care and not telling us what the care is. That's going to be an issue if they need to refer patients out or, anything. How can anyone follow that clinically if that's all they're putting in there?
Yeah, I mean, there's a lot to think about there. And, it starts with risk in some ways. And, I think depending upon the organization that you work with, regarding whether it's the disciplinary process or abuse or anything that underpins where you started, right? Which is kind of the doctor saying, like, I'm going to do what I want. I don't care what you have to say. Well, if nobody in the organization is willing to act upon that, then again, like if it's easy for me to say, like if I was an internal person thinking about this as my career, I would say, well, I might not be in the right environment, right? Like assuming I have what I
Hmm.
consider to be a grounded, reasonable approach to compliance. I think otherwise, having internal physicians who appreciate the work that we do, they're often your best allies in that situation, right? Like they can help diffuse things that we may not necessarily be able to diffuse. Now, one thing that again I will say to providers sometimes is that what we're essentially talking about are stratifications of risk and risk tolerance, right? So I have seen providers who I was reasonably certain would fail like an external audit, and the payer auditor accepted something where I was just like, well, that's crazy to me that they accepted that. It doesn't seem to follow the LCD. But for me, like my standard is I don't want to have to not sleep at night worrying about some issue that some payer is going to pick up on in an audit. So internally, I think sometimes what helps with the frustration on the provider's part is we tend to be more conservative, right? Because if I'm the auditor and I say, hey, you did great, and then Medicare comes in and says, you owe us $250,000, right? At some point, they're going to look at me and be like, what's this person doing? And so I think at some point, I will just tell them, we have different tolerance for risk. Like sometimes that's around prescription drug management where the provider says, I'm the cardiologist, I manage the hypertension, it's obvious. I said continue present management. You can see the hypertension medications in the medication list. So I don't know why I need to say, to continue the specific hypertensive medication at the specific dosage. And I think, we on this podcast have seen instances where payer auditors have said that is not acceptable form of prescription drug management. And so now it's just a risk question, right? Like if you feel like you're willing to take on that risk, I'm not going to be the one who has to repay any money at the end of the day, right? Like, and so
Hmm.
we've heard it all. I mean, I've heard providers tell me, well, I don't know anybody who's ever been audited, and it's like, I don't know anybody who has ever won like $5,000 in the lottery, but somebody does, like that. So it does happen. And it's, again, right, like it's sort of the opposite. Like, I don't know anybody who's been struck by lightning, but like somebody gets struck by lightning. So I don't, to me, I will sometimes basically say, like, while I appreciate where you stand and where I stand, I don't understand if all I'm asking you to do is to say, name the medication and name the dose in your refills, and you're like dying on that hill. I don't understand why you would take that risk. It seems needless to me, right? It's like, why would I cross the street in a somewhat small town without looking both ways? But I just say to myself, well, this is a very small town. But then the one time some car's coming, I'm gonna get like hit. Like, nobody would do that. So I don't understand like why they would do it that way.
Well, and I had a good question recently at the FSR meeting. So I was at the annual meeting. It's the Florida Society of Rheumatology, and we had a really good discussion, and someone had asked a question, what do you do to get this type of education out to our practitioners? Meaning, when we are constantly having to say the same thing about compliance or mitigating risk, how do you get them on board? How do you start to inform them of this so that they're more open and receptive to it? And I'll let you both speak to this as well, what you think, some good options are. But one thing, first of all, the first thing that came to my mind is, maybe everybody needs to go through like a virtual reality of a a court case, right? Having to go through criminal defense or something like that. Or even civil. That's just as bad. Not even criminal. But you know, that joking aside, thinking about everything that's out there now, there's so many podcasts in general. And, there's a lot of podcasts relating to compliance in this industry, but everyone's looking at it somewhat differently. And not everybody's talking about the same subject or topic, for example. So I think finding different mediums like that where we can approach a subject and have a lot of good information being put out that's more casual, that it's not, sitting in a boring lecture or looking at slides that somebody's reading to them or things like that. Just trying to change up the way that we're intaking or getting information out there.
Yeah, I was thinking about this the other day about what I would call like the evolution of the human like attention span. And I was talking to a friend about this, and I think I'm the oldest one on this call, but or on this podcast. That's how you know I'm old,
You
right? I'm
are,
like, what
Scott,
am
you
I on?
are.
And when I was like a teenager, I had to remember like everybody's phone number if I want, or otherwise I couldn't call them, right? Like, I could have a list written at home in a notebook or something, but like I also knew like probably 25 phone numbers of different people who were sort of central to my like universe at that time. And now like the only person's phone number I could tell you off the top of my head other than my own is like my partner, because that's only for filling out like emergency contact stuff over the years. So I wouldn't remember that. And so the way we learn has changed. And I think, getting and holding somebody's attention, if you ask somebody to sit down for like some mandatory 90-minute session on compliance and everything you're talking about has nothing to do with their work, by the time you get to slide 5, it's like, let me just get my phone out and send a couple texts. And, so I think localizing it, one thing I've started to do more of in my work, I mean, we've used all these different ways to select samples. Like with some clients, I'll just say to the provider, like, what do you feel, you would like our feedback on, right? Because we're busy using all these software programs to choose things. And so I think you have to be able to figure out like, how do I deliver value into like, so if you talk about like a rheumatology society, okay, what are like big topics in rheumatology? Like, I know when I audit rheumatology, one of the things that comes up quite a bit is, how do you capture the evolving symptomology of rheumatoid arthritis to differentiate between, stable, exacerbated, and severely exacerbated from visit to visit? Like, how do if the doctor says, well, the patient's doing about the same as the previous visit, I don't know where to go with that, right? Like if they give you specific symptoms, and that may be very different from the guidance that somebody else might need. So, I think I have thought a little bit about shorter, just doing like quick, like 10-minute podcasts that you can listen to in the car. I think there's a bunch of different ways to do it, but I think answering people's very specific questions without a lot of wrapping paper around it, right? Like, when you get something at Christmas and you got to tear through like 20 layers of that tissue or whatever, like getting through that and just kind of getting them what they need.
Yeah, and
Yeah.
Michelle, I know that with you and I, just on our downtime, we joke because we're constantly watching the reels and sending each other funny videos. My favorite is to send Michelle the ones that are related to where you found your sister as a
Yes.
child. And sometimes that may be a dumpster. But it brings to mind, when that's a way to sit and decompress, it's like, okay, why do I want to take information in that way? And to Scott's
Mhm.
point, it's quick, it's easy, it's to the point. And I've even found myself, if I'm looking at a like Instagram video and someone is going on and on forever and ever, or they do it in 4 points because they want all the views and the followers, it's like, you just go past it or you hit the side to make it play faster. But do you have any thoughts about that, Michelle, as far as, what Scott was saying with that intake of information?
Yeah, I do think that the key is to keep it short and focused. There's no need for, all these floofy things about it. Get to the point of what you need them to know. And honestly, they'll probably appreciate you more for it. And then also I think about like, so that used to be what I did. It was provider education, creating the resources, and I was kind of left to my own devices. So, one thing that I learned early on is it needed to be like, if it was a resource I was giving them, it needed to be like visible immediately what they needed to do. And there couldn't be like, you didn't need all these 7 paragraphs leading up to the information. So, I found that it should just be short and focused, whether you are giving them a verbal education, a resource for them to reference. I've even had to go as far as recording myself through PowerPoint because there were a couple of providers who just did not understand what what we needed them to do, like an Epic, for example. And so have multiple different ways typically because people do absorb information differently, but just try to keep it focused and get to the point.
Yeah, very good. So, Scott, to finish us out here, do you have any last thoughts or tips and tricks on what our listeners can do when they're tackling this fun scenario?
One thing we didn't talk about that I do think is important, you have to be a good listener and be able to react to things as you hear them. I don't think I'm different from a lot of educators in that typically, as we've talked about, I kind of have a script or a list of talking points where I'm going into an education session and I'm looking and I'm saying, well, what was this specific provider's identified audit findings, right? And I have all these rules that I've talked about in other forums, right? Like I always talk about documentation, not clinical performance. Try not to tell them they did anything wrong. I just say like relative to the guidelines, what we see. But sometimes when we get so caught up in our talking points, we don't listen to the questions that they're asking or trying to figure out what they need from us and that it may be different from what we're prepared to offer, right? And as we talked about earlier, if we don't know the answer, we probably shouldn't make one up and just kind of tell
Mhm.
them, to look it up and get back. But listening, it's become a little bit of a lost art in terms of being able to establish good communication. And so, if the provider's frustrated That's sort of the easy example, right? If the provider's sort of visibly frustrated, I don't want to pretend that everything is like hunky dory. But if they're asking me a question that's different from what I've maybe planned on, or they're asking me to delve into the chart in a different way than I thought about, respond. And I think a lot of defusing is just, yeah, you have to listen. Yeah, and sometimes that's taking the frustration, but sometimes it's just being prepared to have a sort of substantive conversation about, is something maybe that they're telling you. So you may say you want something documented this way, or you think it should be documented this way, and they're proposing a different way to you, and you think about it and you say, well, that's probably fine too. Well, we don't need to get hung up on that, right? So I think that aspect of communication, and then again, to age myself, right? Like in the movie Airplane, there's a scene in the movie Airplane or Airplane 2 where he comes in and he's like, tell me everything that's happened. And the guy's like, well, first the dinosaurs came. We don't need to do that either, right? And so I think sometimes there's a lot of backstory to our work, but the provider doesn't necessarily need that, right? So if I'm in a meeting, I don't need to be like, well, the guidelines were a certain way in 1995, and then they evolved, right? Like if they ask the question, I can answer it, but I really just need to be able to get right into what they need and listen to their feedback.
Yeah. All right. Well, thank you so much, Scott, for joining us today. It's a lot of fun to be able to jump on here with you.
Thank you. That was fun.
Yes. And join us next
Yeah,
week
thanks
if
for having me.
everything.
It's been a lot of fun.
Yes, definitely. Definitely. Now, next week, if everything goes as scheduled, we should have Sean Weiss and Eric Rubenstein on here as well. So join us back for another session with some great guests, and I hope you have a good week.